Welcome everyone. So my topic is rational pharmacotherapy and the pharmacist's approach toward evidence-based recommendation. As it has been mentioned, I'm a pharmacist and my vision is to have educated patients in the world, and therefore my mission is to be a core character in internationally recognized patient education programs. But for now, I want to work with the rational pharmacotherapies, different fields, and show some examples about them. First topics are about how to add on something, and the second topic is how to avoid something. And in this question, the first one, nabiximols is a good agent. Why? Because in multiple sclerosis, around 28% of patients have a resistant kind of spasticity, which needs some kind of treatment. And here comes nabiximols, which is a divisive agent, because technically it's a cannabis extract, and in some literature it's not that effective. On the other hand, some say it's okay. So my clinical question is, does nabiximols improve the symptoms of multiple sclerosis associated spasticity? And our hypothesis is that yes, it can. We started our meta-analysis from around 3,000 articles and arrived to 14 eligible reports. Our primary outcome is spasticity numerical rating scale. And a responder rate in this. Spasticity numerical rating scale is a self-reported parameter. It starts from 0 to 10, and 10 means worst spasticity ever. So if patients feel a clinical kind of relevant kind of response to the agent, then they can be counted in the responder rate. The outcome, the population is technically in every study same. The definition was similar. But it has to be mentioned that the study design itself was clearly different. Therefore, as you can see here, an overall odds ratio of 2.41, which means at least 2 times more people will respond well to nabiximols, as rather kind of an artificial number. And what we have seen in the clinical cases is that enriched study design are a better kind of population, and therefore the odds ratio of responders could be bit higher than this 2.41. And if we go a bit further, then we have to see by our secondary outcomes that our result is fairly good, because technically every single statistically significant secondary outcome was in favor of nabiximols. So our conclusion is that nabiximols can be used as an add-on therapy in the treatment of multiple sclerosis-related refractory spasticity. But we need to characterize which population we should use this agent. And also we have to mention our limitations, not to mention the high heterogeneity in the study designs. So we have to accept that nabiximols is a good agent in spasticity, but multiple sclerosis have many fields, many symptoms that needs treatment. And as you've seen in the first meta-analysis, we've seen some kind of effect on other kind of symptoms, namely sleep disorders. So, other studies report on good effects other than the approved indication. So, does nabiximols improve the multiple sclerosis associated symptoms further than spasticity and pain? Is the clinical question, and our hypothesis is that yes. And if we are right, then we can broaden the indication of nabiximols. Therefore, we can avoid further medical treatments, and therefore we can decrease the number of interactions. And let's talk a little bit about how to avoid some kind of treatments. And in this case, the pharmacotherapy of lactating women is one of the best to show an example, because it's really challenging. Medicines might pose danger to the baby or decrease the breast milk, it's not good. But also the undue rejection of medications is disadvantageous. And we all know that over-the-counter drugs are not well supervised. And therefore, patients will choose some kind of information source, not to mention internet. So, our aim is to develop a multimedia platform for lactating women, and therefore we want to have the greatest kind of knowledge transfer. So we want to assess the efficacy of knowledge transfer. Sorry. Okay. So the clinical question, what is the most effective way to educate lactating women on the use of OTC drugs in the internet? We have 4 interventions, but we want to make a comparison between them. And our hypothesis is that using illustration is a more effective way than the other. But whether or not we are right, oopsie, sorry, we can improve the efficacy of patient education and achieve rational and safe use of OTC drugs by lactating women. And here's our pilot phases examples. You can see the illustrations about the topic of using painkillers, and there's a screenshot from our video content. So as a summary, our first project is in the state of writing, has finished the state of writing and formatting, and we have submitted our paper to the current neuropharmacology. Our second topic about nabiximols is in the state of data extraction. And our third topic, the lactating women's knowledge transfer, is the orange one. It's in the state of we are drafting the preliminary study, and we have materials for the pilot. And I want to thank you for your attention from a quote from Albert Szent-Györgyi. Science is based on the experience that nature answers intelligent questions intelligently. So if she is silent, there may be something wrong about the question. Thank you.
My first question is connected to the first topic, to nabiximol, and I just wanted to ask what was the reason for the high heterogeneity, and what kind of risk of bias tool have you used?
Technically, the high heterogeneity is, could be explained, for example, could be reasoned by this extremely different study designs. Every study design makes some kind of selection before the study. Therefore, they will respond much better to the treatment than if there's no this kind of selection. We know that as it is a longer period, we wait for adding nabiximols, the lower kind of response is what we see. This is why it's really important that, as I mentioned, the giving of nabiximols and characterizing the good population could be cardiac in the later period.
Thank you.
Thank you for the question.
And the second question is connected to the third topic. You have mentioned you have a video content for patients, and where can patient find it? Is it a website or where?
We want to make a website technically where lactating women can achieve this kind of information. Yes, this is what we say, develop multimedia platform.
But now it is not available for patients?
Technically not, yes. Yes.
Okay.
Sadly.
Thank you.
Actually, it's a comment again. You most likely recognized the so-called védőnői szolgálat. It's a very unique Hungarian system, and I'm sure you already discussed this study with them.
We plan to discuss it with them technically because in a way we want to see whether we have some kind of given information rather than what they can give to the patients as well.
You probably know they see and they, kind of control all the pregnant women during the pregnancy. So this is the only way to reach them, I think, because I have no idea how to control the internet access and their survey. How do they get the information? But it's a well-controlled methodology to collect the information, and not in the literature, because as far as I know, there isn't any kind of basic healthcare system all over the world, only here in Hungary.
Yes. Thank you. Thank you for comment.
Dénes, as always, an excellent presentation. I have two questions for you. Both of them are about your first project. First of all, if you can just go to the results.
What kind of results?
Right. So this is an odds ratio. So the responder rate, does that mean that people said, yes, I respond well to them, or no, I didn't? Was this the question that these articles, like these studies asked?
Technically, yes. We measure spasticity numerical rating scale, and if there's a clinically relevant response by this, a clinically relevant kind of decrease in spasticity NRS, then we say it is a responder patient, therefore we can count responder rate.
How do you define relevancy? Are there any guidelines?
Generally we say it's 30%, but in shorter kind of trials, like shorter than 1 month, we accept 20% as well, because it is declared that if a patient achieves 20% in this trial or first period, they will achieve with time 30% as well.
Thank you.